She's a nurse, and she gave me a book by Dr. Mary Enoch entitled Eat Fat, Lose Fat. Dr. Mary Enoch is a nutritionist, did her PhD work back in the early 60s, studied cultures throughout third world countries, and in her training she found that through nutrition a lot of diseases can be healed, so then that was her focus. So I had a patient, this patient lives in Soledad, a 21-year-old gal who had some issues with increasing weight, and she had a thyroid condition. And with that thyroid condition, her TSH level, it means something might mean something, 5.3, so it's elevated. And I said to her, well, your choices are we can go with Armour or Synthroid or a drug like that, or if you want to try something really radical. I just got to reading this book, and what this book talked about is the fact that raw coconut oil will actually stimulate your metabolism. And she goes, don't give me any medication. I said, fine. I won't give you any medication. We'll try this for 6 weeks.
What was the oil? I'm sorry, what was the oil?
Raw coconut oil. Raw coconut oil. Pure, unrefined. There you go. So after 6 weeks, I also told her, I said, just cut your carbs. Just cut the carbs out of this. She's Hispanic, and she loves her carbs. Like many of us anyway, who like carbs. So 6 weeks later, she comes back 20 pounds lighter, and her TSH level went from 5.3 to 3.5. And I thought, holy cow, what the heck just happened here? So I said, congratulations, we don't have to go with any medications, keep doing what you're doing. And that really kind of began to open my eyes with regards to nutrition. So after I pursued that further, looking at other nutritional deficiencies that I could go after, I was then approached by a former CEO who helped modern family practice way back when it had some financial issues. And with that, he says, oh, let me tell you about this program. And he told me about how the fact that he lost, I don't know, 15, 20 pounds. I thought, great, good for you. I really didn't care much about that. What really was interesting about this whole situation was his wife, who was in her 70s, had chronic elevated cholesterol level around 240 to 260. I think it was a genetic thing. But in any case, that's what she told me initially anyway. She went ahead and went through this program too. She was a little bitty woman who had nothing more than 10 to 15 pounds to lose. But what that did in that process, by the mechanisms that were used to do that, her total cholesterol went from 240 down to 160. And I thought, ooh, that's interesting. So for me, I thought, okay, can this be this program a means to an end? So that's where I really became involved with using a ketogenic diet to help patients as a means to an end to have them reverse their chronic diseases. So I'm going to talk a little bit about some of the things that have happened with regards to where we are as a country, where did these concepts of fat being bad come into play, and cholesterol and the lipid hypothesis, and what some of the data actually that's now coming out is showing something different. So I'm going to sit down here. It's a little bit easier for me because I'm going to be pushing a button on the computer. And if you need me to talk louder, I can talk louder too. So just let me know. And slide here. So this discussion tonight, I'm going to get into a history of the lipid hypothesis and how it has led to a focus on fat as a contributor to ischemic heart disease. Also, nutritional issues that are contributing to chronic diseases, including, has anybody here heard about type 3 diabetes?
No.
So this is rather interesting. Identifying cultural elements that reinforce diets associated with radical increases in chronic diseases, what we're seeing going on in this country now, weight gain and obesity. Describing how risk factors for chronic diseases share a common cause and what we can do to correct it. Why popular diets haven't worked over time. Learning about, I'll tell a little bit about our program, what we're doing, which is a scientifically designed nutritional program that facilitates the body's ability to heal itself and provide some case summaries. One of my presuppositions as a physician is that every cell in your body wants to heal, wants to thrive, and wants to live. This concept that we hear all the time, and I have it reinforced with these Crestor commercials, is that LDL is bad cholesterol and HDL is good cholesterol. We want to lower the bad cholesterol, we want to raise the good cholesterol. Why would our liver be producing cholesterol to kill us? Does that really make sense? I mean, do we really think that our organs are out there ready to attack us? I think it's kind of a concept that has been too simplified, and I think it's a negative concept, and I think it's a fear factor. And I don't think that the best medicine is provided under fear. I think best medicine is provided under understanding as to how our body works. And the way that I describe cholesterol is I say our liver is producing cholesterol to repair endothelial damage. What is the endothelium? It's the innermost layer of our artery. And our artery can develop what I call a pothole. They'll call that a plaque. What do you do with a pothole? With any pothole, you got to fill it with asphalt. That asphalt has to necessarily be hard in order to mimic the surrounding asphalt around it, in order for the density to be equal enough so that cars can drive over it again. If you put something in there like applesauce, the pothole will only get bigger, right? Okay, so we need some hardness. There's a necessary component to that. Well, that's the role of the LDL particle. Well, then there's the role of the HDL particle, which is a big fluffy molecule which grabs onto the excess LDL particles. And as that takes away the excess LDL particles, then we have this process of the body cleaning itself, and that's what our liver does. So I like that concept a lot more than what we've been hearing over time, and it's something that needs to be changed as far as I'm concerned. So I'm going to talk a little bit about Ansel Keys. Anybody ever hear of Ansel Keys? He is the father of what we could call the lipid hypothesis. He's a physiologist who made the cover of Time magazine. And he came out with this hypothesis back in 1953, I believe. And he said a couple things, and we've all heard this. Saturated fat raises cholesterol, high cholesterol clogs arteries. But it's not just that simple. What do we know now? What we know now is that inflammatory markers are more predictive for heart disease than even the cholesterol. And so what are those inflammatory markers? C-reactive protein, myeloperoxidase is another one, homocysteine is another one. And when cardiologists are doing biopsies on patients that have had, not biopsies, when they do necropsies or autopsies on patients that have had heart attacks, they didn't find elevated plaque and cholesterol. They found it was these other inflammatory markers, which were the factors which resulted in the demise of those patients. So anyway, what did Ansel Keys do? He looked at 22 countries. And of those 22 countries, he cherry-picked 6 countries. And in his nitpicking of those 6 countries, there he saw saturated fat and he saw incidence of heart disease. But if you looked at the data from all 22 countries, he would have never been able to make that conclusion. And were these what they call double-blind studies that were being performed? No. These were just correlations that he was looking at. And when he proposed this to cardiologists back in the 50s, they said, well, where's the proof of this? And they rejected his notion. But that didn't stop him, because after a while, he decided to become a board member of the American Cardiology Association. And after he became a board member, he became the president of the American Cardiology Association. And then at a certain point, our government approached him. When our government did studies on malnutrition in the early 70s, they came up with something, and some of you remember George McGovern. And he came up with a government report that came out, and it suggested that Americans eat, we've all heard this mantra now, many years over, Americans eat less fat, less cholesterol, less refined and processed sugars, and more complex carbohydrates and fiber. Well, the first question I want to ask tonight is, what's the difference between sugar and a complex carbohydrate? Physiologically. Nothing really. Glucose is glucose. But when it gets to that level, there's really no functional difference, because they're both going to do the same thing. So in this statement that our government made, what I saw with that was, okay, there's a contradiction. They want me to eat less sugar, but they want me to have more sugar in the form of complex carbohydrates. Bread, pasta, rice, things like that. Rice isn't one. So in 1977, U.S. dietary guidelines came forth. Increased carbohydrate consumption to 55 to 60%. Decreased fat consumption from 40% down to 30%. Reduce saturated fat down to 10%, and increase polyunsaturated fat. Limit cholesterol to about 300 milligrams per day. Reduce sugar consumption by 40%. So we want to increase carbohydrate consumption, but we want to reduce sugar consumption. Once again, here we go. And reduce salt consumption to about 3 grams per day. So the results are beginning to come in based upon what we as American citizens have done very well since 1977 for following these guidelines. And these guidelines have made their way into our culture in many, many ways. Ta-da, the food pyramid. Here we go. So this is kind of what came out in 1977. So we can look on the bottom, and I'll break this down into macronutrients to kind of give a perspective on it. Bread, grain, cereal, pasta. Okay, carbohydrate. Call it sugar. Vegetables. Well, you break down, you remove the fiber, you got the sugar. Then you got fruits, fructose. Okay, there's another sugar in there. You got some fiber too. That's good. Dairy, which is all three food groups. Protein, and then on top it says fats, oils, and sweets. Okay, so if you break that down, that's roughly about 60 to 70% carbohydrate or sugar. So was that our diet before 1977? No, it was not. If you go back to the 60s and 50s and 40s and 30s and you look for pictures of obesity with your great-grandparents and so forth, you're not going to see it as much. You're really not going to see it as much because their diet was different than this diet which was proposed, which we have followed very well since 1977, moving towards 2015. Sugar is as addictive as cocaine. Blunt statement. Well, obesity is obesity. So here we see a cross-section of the brain. On the left side, you'll see a normal brain. In the middle, you'll see cocaine addiction. And on the right, you'll see a patient who is obese, who is addicted to his carbs. And you see the same areas of the brain light up in the same fashion. See if I can turn this video on here. This is rather interesting. No, hold on here. We're going to stop that, and I'm going to have to go to my volume. Okay, here we go. Okay, one more time. Right, so I think that's pretty informative, talking about how our brain is having to deal with what we're doing with our bodies. So, effects, as I talked about the results already. This is a very interesting study done by Tim Noakes. He took this data, you can see here, Journal of the American College of Cardiology, 2012. This is rather interesting. So this is where a study shows the cumulative incidence of ischemic heart disease for different random blood glucose concentrations. So over here you can see the red, average blood sugar, 198 milligrams per deciliter. That's pretty darn high. That would be a diabetic patient. Okay. You can see in the green, here's a patient with a blood sugar level of 90. So here we come along, here's the age. By age 60, 62, boom, here we see ischemic heart disease for someone who's averaging a glucose level of 200. Can you make the same correlation with regards to following cholesterol at a certain level? It's too broad. It doesn't give you the same correlations that you're seeing here. Look what happens here with this blood sugar less than 90. Look at the incidence of ischemic heart disease. If a person has kept their blood glucose levels lower, they got about 20 to 30 years of a lifespan, 20 years there, 22 years of lifespan there, before they saw evidence of ischemic heart disease. Pretty interesting. This is, once again, just looking at blood sugar levels, glucose levels. Now, here's incidence of heart attack, incidence of myocardial infarction following the same glucose levels. We'll see here 198, 162 to 197, 126 to 161, and so forth all the way down. Age 68. Now these are incidents of heart disease. It's not predicting myocardial infarction. These are the incidents of myocardial infarction. So this number here now is occurring here at age 68, compared with patients who had glucose levels of less than 90. Where did that happen? When did that happen? Beyond age 90. Pretty phenomenal when we begin to think about, okay, should Evansville Keys been chasing glucose versus chasing cholesterol? Or that? Probably. If he did, I think this would have changed a lot of this dialogue that was happening, especially with what we see with big pharma in this country with regards to the pushing of statins and medications like that. Come on in, we're waiting for you. Have a seat. Hopefully I won't scare the daylights out of you. Okay. Here's another slide. This slide also came out of that talk, and this came from the Annals of Internal Medicine. And in this case, we're looking at, so some of this is technical, so you can always stop me here. But one of the tests that physicians measure when they look at diabetes is they look at the hemoglobin A1C level. Hemoglobin A1C is a measure of a red blood cell, and red blood cells it has a life of about 90 to 110 days, somewhere in there too. So if they can follow the glucose on that blood cell, then that kind of gives them an idea about a person's control for their blood glucose levels. So here we see, and how we measure that? We measure that in terms of percent. So 5%, let's see, 6%, 7%, and then above. And you can see here, when it's above 7%, we're calling that known diabetes. So in this instance, we're looking at all-cause mortality and coronary heart disease events. So if the blood sugar levels are here in the normal range, so we kind of call this more of a normal range, less than 5.7. Okay, that would be where you can see it's kind of paralleling about the same. Above 5.7, that's where you may hear the term pre-diabetes for a patient. This is where we begin to see increased insulin resistance in the body, where the fat cells are not accepting the glucose being grabbed by insulin and being pulled into that fat cell. This is where we're beginning to see problems. So here we go, 6.5 to 6.9, all about the same, and then look at the spike. Boom, right here. We're seeing a spike of coronary heart disease events. This is events. This isn't risk for, this is events. Once again, what are we looking at as our marker to find this? Now, in medicine, people always love to find one thing. Well, we know it's not just one thing, but we know that this is a pretty big thing, especially if we know that 70% of what we're eating is the thing that we're talking about here. And when we start to think in those terms, we begin to say, oh, okay, it was a stack loaded against me. Maybe so. So, in other words, a 1% increase, remember, from 5 to 6, 6 to 7, 7 to 8, a 1% increase in hemoglobin A1C concentrations was associated with a 20 to 30% increase in cardiovascular events and all-cause mortality in men and women 45 to 79 years of age. Pretty compelling. So, I mentioned something about, real quickly, type 3 diabetes. This is a lot of interesting data that's come forth, and so here now they're looking at what are the effects on the brain. Well, I'll read this here. Currently, there's a rapid growth in the literature pointing towards insulin deficiency and insulin resistance, and you find out with diabetes, as mediators of Alzheimer's dementia-type neurodegeneration. But the surge of new information is riddled with conflicting and unresolved concepts regarding the potential contributors of type 2 diabetes, metabolic syndrome, and obesity to Alzheimer's dementia pathogenesis. So it's like they're looking at it, they don't quite completely understand it. We conclude that the term type 3 diabetes accurately reflects the fact that Alzheimer's dementia represents a form of diabetes that selectively involves the brain and has molecular and biochemical features that overlap with both type 1 diabetes mellitus and type 2 diabetes mellitus. The brain doesn't have a defense mechanism, whereas the rest of our body kind of does. And so they're really kind of beginning to go after this kind of hard. So if there's going to be a correlation between wanting to lower dementia in older populations as the baby boomer generation kind of is carrying forth in our country, well, this is going to become a larger and larger issue. And if we identify that glucose is a part of this and diabetes is a part of this, and if we can reduce that factor or reverse that factor, then maybe we can slow down the incidence of Alzheimer's dementia. The problem: 2 out of 3 American adults are overweight. 85% of Americans are overfat. 1 in 3 U.S. children, and I think that number's growing, are overweight or obese. I'd say this number's probably plus 150 billion per year at this point, spent by Medicare, Medicaid, and private insurers on obesity-related health care. Once again, how did we get to obesity? Let's go back to the food pyramid. Let's not forget where this kind of came from. Obese people consume an estimated 40% more healthcare dollars compared to non-obese people. Let's go over that one. So, causes for it: excess weight, excess body fat, sedentary lifestyle, diets excessive with sugars, carbs, and fat. Oops. Let's move forward. Here we go. Okay. So this is rather interesting. Here's a woman who we can see at age 20, we're looking at body weight of 126 pounds, muscle, about 45 pounds of muscle, 29 pounds of fat. Move her forward.